You guys hear me?
Yes po.
Okay, thank you. Preparing also yung ano kasi. Okay. Number 56. No, a dental post is always necessary, even if less than half of the original crown structure is missing, as the core alone cannot provide retention. Oh, what's the answer to this? What's your answer? Dalawang choices lang. True or false? A dental post is always necessary, even if less than half of the original crown structure is missing, as the core alone cannot provide retention. Answer. Dalawa pa lang sumasagot. 1, 2, 3, 4, 5. I'm also checking kung ilan na nakabalik ang kasi baka connected na kayo. 7. Na-outnumber na ng ano. Mas marami na ngayon B. Okay? Mm-hmm. Okay. So it's like this, no? In school kasi, usually, no, what we talk about is post and core, post and core. Diba? Now, of course, if you put a post, definitely you need a core. Okay? So the post can be a prefabricated post or it can be a customized post. Now, customized post is usually fabricated no, along with a core no, that's already attached to it. Prefabricated post, no, you build up no a core no around well on top of it, right? Okay, so what is this core needed for? The core essentially supplement no the remaining crown tooth structure, the coronal tooth structure, no, to retain your crown or the final restoration or whatever type of prosthodontic crown it is. Okay, now does it always follow that you should have a post when you put a core? Actually, no. Okay, so there are instances wherein no a post is not necessary. You just need to build up a core. Okay, so you can just place no and this is what we do actually no for our cases wherein we just use a final restoration of crown. Diba some of you your final restoration for your endodontically treated teeth are ano lang complete crown, 'di ba? No? So yung pag-build up noon, no, the fact that you built up no this tooth is already the core, okay? No? So of course the core can be made up of different materials. It's not just your composite build up, okay? No, but it's just one of them. So of course, you can have other materials for this. Now before, there was also amalgam as an option, no, or but for the most part, the recommended material now, no, is your composite, preferably dual cured composite, no, so that you can also ensure that it's cured inside and out. No? Pero pwede rin naman yung the conventional composite that you're using. Okay? Now, you will incorporate this composite, of course, inside the chamber also. Kaya nga you have your GIC first and then the composite. No? Yan. So, yan. Ganun din. That's why you can do your crown prep over this restoration that you did after obturation, di ba? Kasi that's actually the build up na, the core build up na that you're doing. Okay? No, and then for those of you which have cases, no, that have lost the teeth, no, have lost um a lot, no, of their coronal tooth structure, such that you need to add more retention. Then that's when you need your post before having a core. Now in terms of the post, there are several materials that and types also. So you have your custom, and then you have your prefabricated. For prefabricated, you have different designs, um, tapered, and active. So when you say active, they have serrations or they have threads, not are not recommended. Okay, so we usually recommend parallel posts. Ideally, actually, for endo, no, the most commonly advocated post material now is fiber post, particularly, no, if retreatment is needed, because fiber post would allow ease of retreatment. Number two, also if there's trauma, no, which if this tooth experiences trauma, no, a metal post, no, would actually cause the root fracture, no, in all likelihood, no, while a fiber post, it's not likely to happen. Okay, there will be a better prognosis for this. Okay, of course, this is aside from or other than the aesthetic issues also. Okay, but of course, a fiber post cannot be retained with GIC. We use resin luting material, no, to retain our fiber post. Okay, ayan. So, ang dami ko na sinabi tungkol sa post sa isang question lang. Okay, so yeah. So, what is the primary purpose of dental core in restorative procedures? A, to prevent caries from formation in the root canal, to support and anchor a mass of restorative material to lost tooth structure, to seal the pulp chamber permanently, D, to eliminate the need for crown restoration. Okay, so we do not build up the core just because we want to save up on money, so you don't need to put a crown, no. So the core, no, will just serve as support for the lost tooth structure, no, and also for to help, no, with the retention now of your final restoration, which is a crown. Okay, yan. So yeah, so the answer here, no, will be letter B. All right. Okay. 58. Which of the following are essential considerations for a successful crown restoration? Okay, so you can see among the choices, there's all of the above. Okay, so if you see two of them, of A, B, and C, two of them is true, then in all likelihood, the answer is all of the above. So let's test this one. Letter A, inclusion of a ferrule with at least 1.5 mm of encircling cast metal. Okay, so a ferrule, no, uh, the ferrule around the canal is has different would say standards, depending on the principle that you're following. No, so there's minimalist style, wherein you don't want the canal to be prepared so large, to incorporate large post. No, so in this case, you will just pick, a post, that will fit, the canal after you've removed the GP there. Now if you cannot find from your set of prefabricated posts, a post that will fit this, then consider, of course, resizing or enlarging the canal space. But of course, you will need to consider, the surrounding remaining dentine around it. Okay, no, so uh, in the case of what do you call this? In the case of wanting to have at least minimum, you want at least 1 millimeter of ferrule, no, around this canal space, no. So, and for as for the height, ideally it should be 2 millimeters. Okay, no. So the minimum is 1 millimeter of ferrule, no, above the canal. Sorry, above the margin, no. But it's a very barest minimum of ferrule, and then you will increase this with the core. Okay, no, but the ideal will be 2 millimeters. Okay, that's the, well, at least that's in the uh, what's indicated in the book. Okay, preservation of biologic width coronal to the alveolar bone. Okay, so in terms of the biologic width, we know that violation of the biologic width has a very good likelihood of causing periodontal disease, specifically periodontitis, no, or attachment loss, no, to for this tooth, no. So that's why the biologic width, no, has to be protected. Now, you want, no, to preserve this 2 mm, about 2 mm, no, of biologic width that's not violated. So technically, the recommendation is from the gingival margin up to the alveolar crest, gingival margin up to the alveolar crest, about 4 mm. Okay, no, height. Okay, and then from the, of course, this is average. From the base of the pocket to the alveolar crest, about 2 mm. Okay, right. 59. So wait, the letter C. Maximize surface area and tooth height for retention and resistance. Ideally, no, you do want to preserve as much of the natural tooth structure as possible. Okay, this is a given. Okay, so inadvertently, for some cases, you will be reducing a lot of dentine, which cannot be helped if you really need to facilitate your cleaning and shaping of the canal, and finally the obturation. Sometimes errors might occur, but in general, your target, would be to preserve sound dentine, okay, as much as possible. Okay, and this goes both for the surface area, no, and the tooth height, no, for your retention and resistance form. Okay, so retention and resistance, okay, are both necessary for the longevity of your final restoration. Okay, no, so the usual recommendation for the minimum height of the shortest wall of your crown prep, no, should be 3 mm. Okay. So of course, again, some references would say other things, no, but that's the usual amount, no, that or height that's recommended. Okay. So the answer for this question, number 58, is letter D. Okay. So these are all important. Okay. 59. Now, which of the following statements correctly describe key considerations in post space preparation? Ayan. Heated instruments like pluggers with eucalyptus oil or chloroform can be used to remove Glycopercha. Yeah, that's possible. Letter B, post drill systems involve engine-driven drills for Glycopercha removal. You can also, there are specific engine systems for some prefabricated post designs. Okay. Letter C, a minimum of 4 to 5 mm of gutta-percha seals should be preserved apically. And well, letter D says all of the above. Okay. Now you might see some references which would say 3 to 4 mm of GP. Should be left apically. No, but this is also what's in our textbook. 4 to 5 mm at the apical should be preserved. So this is important to remember because um, there will be instances where the root, of the canal will not be that long, and but you need a post in order to retain, the crown, so you will be reducing the GP in the canal, for this post to have a manner of retention there. So you will need to ensure that a 4 to 5 mm of gutta percha will be left, no, in your obturation at the apical region. Okay, so this is essential for your planning. Again, even before you start your endo, you should already make plans for this. Now, do you think you can do this? What will be the minimum length of your post? What's the minimum length of the post? Length of the post length. Mm-hmm. Sino pa? Minimum, no? Meaning pwedeng longer. Mm-hmm. Minimum length of the post. This is something na meron siyang ano eh. We call this, there is a condition. Yan. Mm. Oh, by the way, let me show you yung ano, the rule. The rule. Please stop sharing this one. Send something else. Kasi I know very few of you actually read the book. Okay. So, yan. So, the minimum thickness of your ferrule should be 1 millimeter. And then the minimum height, 2 millimeters. Okay? So, ano yan Agree na kayo dyan Okay. As I said, no, actually, no, barest minimum is 1 mm, but really ideally 2 mm height. Okay? And this is why I really cannot accept what that speaker said, no, yung si biomimetic, si Miss Biomimetic, si Doc Biomimetic. Anyway, saan ba yung aking ferrule? Sorry, impost. Okay. By the way, these are the core materials. Okay. Now, this is the most common. Dual cure resin composite. Post. Okay. So, there are these are the clinical considerations for post length. Okay. Apical obturation. Okay. No? And if the root or the canal is long, then it's not an issue. Actually, of the length, definitely you can have uh, as long as you want. Okay. Now, ayan, these are the different principles. Saan pa yung aking, Actually, you want to choose. Sorry, napunta na sa looting. Anyway, na sa looting cement. Ayoko na hanap yung slide. Anyway, you, your minimum, no, should be the same length as the crown. No? So two-thirds of the root or the length of the crown, whichever is longer. That's the answer for that. Okay? But whichever is longer, ha? Okay. Shelly. Okay. Ayun, tinamad na maghanap dun sa slide. Hmm. Okay. So, next item. Ano tayo? Hmm? Ano ba? So, the difference with the court and see the option. Which of the following statements correctly describe key consideration post-space preparation? Yan. Uh, heated instruments like loggers and with eucalyptus oil. So you know that eucalyptus oil or chloroform, no, are solvents for obturation. No? So chloroform is not readily available now. So use eucalyptus oil, oil of orange, or lemon oil. No? These are also the same materials that are used for retreatment. No? Now ideally for some endodontists, they don't like using this for preparing for post, no, because they kind of liquefy, no, and make cleaning up of the GP a bit more tedious for them. No? And also another issue, of course, would be possibility of difficulty in controlling. No? So usually they would recommend the use of drills, no, instead. Okay, yeah. Anyway, number for number 59, it's all of the above. Number 60. When using a prefabricated post system to restore a posterior tooth, what is the most desirable post design? Okay, definitely threaded or screw type. No. Okay. Now, tapered design, no, is a problem because this tapering actually promotes a wedge effect. No, that's also a possible source of fracture. Now, so ideally for retention, you want to get help from the parallel sides. No, although serrations are not really that desirable, no? Or necessary. So usually nga smooth eh. No, but yung threaded kasi definitely or screw, pareho lang yan, threaded and screw type. Out talaga yan. The tapered, no, is not recommended because of the wedge. So because letter A has yung parallel and the serration is not as bad as screw type, no. Because serrations are only there so that the luting cement will hold onto these serrations. This is the opposite of screw type or threaded type because for screw or threaded type, you actually screw in the post into the canal, and this causes a lot of cracks and creases, no, inside the along the canal walls. No? Kaya nga sabi ko ito palang out na siya. Okay? So the best answer for this one is letter A. Okay? No? Kasi yung tapered din is also something that's definitely not desirable. Okay, number 61. Which of the following best describes a comprehensive approach to managing endodontic procedural accidents? A. Ignoring minor errors if the patient is asymptomatic and continuing with treatment as planned. B. Identifying the type of error, determining the cause, implementing appropriate management, and considering the effect on prognosis. No, so because endodontic procedural errors would include minor ones and some are a bit bigger. No, so but the question here is a bit general. Letter C, immediately referring all procedural accidents to an endodontic specialist, regardless of severity. Letter D, preventing procedural errors by using excessive force and speed during canal instrumentation. So definitely, letter D is not good. Now, what I always say is endo is done with finesse. Okay, so excessive force is something that we do not want to do in endo. Okay, yeah. But a good practice, no, would be to identify the error, no, identify the type of error. With this, you can now seek out, no, what, or come up with the best course of treatment or the plan, changing plan for this, no, as soon as you figure out what's the cause. Okay, no. So when you see an error, okay, you detect an error. Second, see what was the cause. Can you remove the cause? How do you manage it? Okay, so these are the things that you need, and then of course correct. Okay, after that, of course you consider the prognosis, has it changed, no? Okay, so letter D. Okay, 62. Which of the following statements best reflects the importance of understanding procedural accidents in root canal therapy? Okay, so ganun din, understanding the cause, prevention, management of procedural accidents is essential, and as these unforeseen events are usually, can negatively affect the prognosis of the treatment. Okay, now so while accidents or errors can happen, no, at any point, no, um, uh, you need to uh, be mindful, no, because these can happen at any point of during your treatment. You have to be mindful at every step, no, so that you're able to address them immediately. Okay, so yeah. Do you stop doing your endo because you made an error? Not necessarily. No, a lot, actually, as a matter of fact, a lot of them are manageable. No, so it's really actually quite saddening to see, no, obviously abandoned endo cases. Okay, and unfortunately, also some of these patients think that they're done, no, with the endo, no, so they think that the dentist finished their endo treatment, no, not knowing that these were actually abandoned. There are cases like that, no. I've encountered a case that the mandibular molar, the patient thought that uh, yeah, this was endodontically treated and finished case, no, but we took a radiograph, we didn't see any radio opaque material in the canal. So you're like, where is it if it's endodontically treated? Okay, but we we opened it up. We removed we did the access, and yeah, the because the reason why we knew that it was initiated is that there's evidence of the restoration, and then there's also a bit of evidence of the shaping of the canals. Yeah lang, walang obturation. No, so we opened it up, and well, to our surprise, no, what we saw was GP, no, uh, blocking a perforation. Okay, so kind of used the GP to patch up a perforation, and then the case was abandoned. So, but all the way the patient thought that the endo was done. Okay, so please don't do that, ha. Nakakaawa yung patient na ganyan. Magbabayad na matino yan. Okay, no, so if you commit an error, okay, no, so basically you have to be really attentive, no, as much as possible. Try not to make a major error. Okay, no, you prepare well so that it doesn't happen. Okay, and yeah, but once you understand the cause of these possible errors, you can also understand how they are prevented. Okay, and you know how to manage them. Okay, so letter C. 63. Which of the following is a procedural error most likely to occur during access preparation phase of root canal treatment? Apical transportation, instrument fragmentation, lateral or cervical perforation, voids in obturation. So, at what part of the endo access preparation, which is a likely error during access preparation? So, well, apical transportation is not something that will be done unless you're already doing your cleaning and shaping or biomechanical preparation. Okay? No, instrument fragmentation. This is when you're possibly when you're extirpating or debriding and doing your biomechanical preparation. Again, that's possible, but during access, it doesn't make sense. Letter C: lateral or cervical perforations. No, so in the course of looking for the canal orifices, it's possible that you'll actually perforate laterally or cervically. Okay. Letter D, voids in obturation. Again, no, this is too far off into the steps of your RCT. Okay, so the answer here is what? What's the answer here? Letter C. Okay. 64. What is most likely cause of procedural error known as gouging during endodontic access preparation? Iba ang gauging sa gouging. Gauging, G-A-U-G-I-N-G. Gouging, G-O-U-G-I-N-G. Gauging is just trying to estimate the length, no, of the canal, for example. That's gauging, G-A-U. Gouging is removal of sound and tone due to poor understanding of tooth anatomy. Okay? Gouging. So, you unnecessarily remove dentin. So, again, in this case, in number 64, this case is a matter of really knowing what gouging is. Because if you don't know what it is, it might be a bit difficult. Unless you consider, if you don't know what gouging is, but you consider that the next statement is during endodontic access preparation, then once again, this part of the question will help you. No? Why? No, kasi nga during access preparation eh. No? So, excessive condensation obturation material? Obviously not, because you're not obturating yet. Access preparation pa lang eh. Letter B, inadequate irrigation of the canal system. Again, this is what? During cleaning and shaping. Okay? Letter D, overextension of working length beyond apex. Again, no, this could be from working length determination, but this is not access preparation. So the only thing that is related to access preparation is actually letter C, and that's why it's very easy to answer this one. Okay, yeah. Number 65. Which of the following materials which of the following materials is most appropriate for managing gouging that occurs in the radicular middle or apical third of the root during endodontic treatment? Okay, anyone like to answer this one? So choices are composite resin, glass ionomer cement, mineral trioxide aggregate, zinc phosphate cement. Gouging at the radicular middle or apical third of the root. C. Okay, mineral trioxide aggregate. Okay. You can't really place the other things no, at the radicular middle third. Okay. Yeah. Number 66. What is the common cause of lateral, cervical, or bifurcation perforation during access cavity preparation in endodontics? Letter A, faulty burr angulation to the tooth's long axis and failure to evaluate radiographic crown root alignment. Letter B, overextension of obturation material. Letter C, use of rotary instruments in dry canals. Letter D, excessive irrigation with sodium hypochlorite. Again, it says during access preparation. So you can already eliminate some of the choices. Here, okay, have letter A. Okay, let's see. 67. Sorry, na the drain na I'm running out of energy kasi nga usually Sunday is my my only for those of you who don't know kasi some of you know already. I have a, I have a condition which gets me really tired. Hindi lang obvious kasi in school usually I'm always on the go. But I actually have a systemic condition, no? And I usually need my Sundays talaga. Tapos yung Monday ko pa na day off, nagkaroon din ng class. Kaya nawala rin yun. Anyway. So, 67. Which of the following practices help prevent perforation during access preparation in endodontics? Letter A, using endodontic explorer and radiographs to guide burr angulation and depth. B, ignoring radiographic angulation, obviously not. C, advancing the burr quickly and deeply without preoperative assessment. Again, this is obviously wrong. D, relying solely on tactile sensation during access without radiographic planning. So I guess the answer here is very obvious. No? No, when you have these types of choices, no, wherein you have choices that are obviously negative, no, so you can eliminate them immediately, right? No, so 67 is letter A. No, and I hope you use this in your dental practice as well. No, your endodontic explorer is really very important during access preparation and orifice location. Okay, number 68. Which of the following best describes a common cause of ledge formation during root canal instrumentation? Okay. Um, A. Consistently using lubricant and flexible night tie files. Common cause of ledge formation. So something that's not good. Okay. B. Using large stiff files with excessive pressure and skipping files sizes without proper recapitulation. No. C. Maintaining accurate working length, performing circumferential filing. D. Frequent irrigation and patency filing with small files. Okay, so you're getting more consistent now with getting the right answers. You're getting quicker and you're able to analyze na the questions. No, so yeah, that's good. No, kasi uh you need to be more confident, no. And the only way that this can happen is if you practice, not just uh, not just study your references but also practice answering. Okay, yeah. Number 69. 69. What is the recommended approach for managing a ledge formation during root canal instrumentation? Okay, recommended approach for managing ledge. A. Skip to larger files to bypass the ledge quickly. That's not gonna happen. Diba? That's not gonna happen. Letter B. Use an ultrasonic tip to remove dentine aggressively. Well, that's too much. Okay. Letter C. Use a small prevent file. Locate the ledge and gradually file with short up and down strokes. So essentially, you're bypassing this uh, uh, ledge. Continuing filing straight without bending the file to avoid damaging canal walls. Okay, letter C. Okay, letter C. Okay. I think we can go until 70. Which of the following practices helps prevent ledge formation during root canal preparation? Okay. Uh, A, skipping files to save time and reach the apex faster. Of course not. No, this is it's obviously negative. Apply strong pressure to push the file through curved canals. No. As I've said, endo is done with finesse. Okay, so definitely strong pressure is not recommended. Letter C, pre-curving the apical 3 to 4 mm of the file and using circumferential filing. Yan. And letter D, using only a single irrigant and filing randomly inside the canal. Okay, you already know that there's something wrong here. So this is actually what we did nung for last Saturday for the not yesterday. Kasi walang clinic yesterday. Last Saturday. This is what we did for the case that I told you about earlier, yung wherein the canal was a bit difficult to engage into, no, the entire length, no, and there was almost ledging, almost, no, but I, I was like, oops, okay, I can see the potential here. No, no, no. Um, so I had the student recurve, no, the file, and use tactile sense, no, to go around, no, this and bypass that almost ledge. No? So di pa naman siya ledge actually, almost ledge na kasi it was going straight instead of curving. No? And of course, I had him remove some of the initial coronal tooth structure pa to get a more straight access. Okay? Ayan. So, I think we can stop here. So tiring to read all of these. But I'm also, wait lang I want to share this. So, you have, you can see these resources online if you want to. Um, yan. Okay. So, hindi kasi ito naka-presentation. There's a bit of delay. Okay. So, if you look at this table, you will see the different pulpal diagnosis. No? Uh, some of you kasi get really confused pa rin until now. Okay? When it comes to endo, there's always pulpal and apical diagnosis. Always. Pulpal and apical diagnosis. And what you're reporting as the diagnosis should be the current condition of this tooth. No? Both the pulpal and apical condition. Okay? So, no? In terms of the pulpal diagnosis, now you have to remember, no, apart from comparing the normal tooth with the normal pulp tissue, no, to your teeth that are likely for endo, now there are also instances wherein you will be doing, no, endo on these teeth with normal pulp tissue, for example, for pre-prosthodontic reasons. And even your reversible pulpitis, which normally you will just do or make a restoration, di ba? No, you don't need to do endo. But then again, for some instances, prosthodontically, for example, you will need to do endo on them. So that's why they're also included here, no, as for your a possible condition which could undergo root canal therapy. Okay. Now, in terms of radiographic findings, no, a tooth with reversible pulpitis can act will be normal, no, or can have widened PDL. In terms of thermal testing, they're usually cold to sensitive they're also almost positive, almost always positive to cold. No, wait lang. Can you see ba? Sorry tagal nang may delay sa akin. May lang. Can you see the presentation or no?
Wala pong ano.
Hindi lumalabas. Okay, wait lang ha. Let me just transfer this to my drive para mas makita. Hindi kasi siya sa drive eh, nasa ano ko lang. Ah, puno na ba ang laptop ko? Kaya ba ang bagal? Or ano lang talaga? Or mainipin lang? Hindi ko na alam. Saan? And review. Bagal. Hmm. Okay. Ayan, I think kita na, no? Okay. Ayan. So, uh, yeah. So for reversible pulpitis, this will also come. The patient will also complain of cold sensitivity. Now, usually though, this patient will report that this resolves immediately after removal of the stimulus. Okay. Now, as for the radiographic findings, they can have normal or widened PDL. Oh, by the way, no, for the radiographic findings, no, it doesn't mean that you diagnose your these pulpal diagnosis using this periapical descriptions, ha. Okay. No, so yeah. Now for EPT, no, as long as the pulp tissue is vital, then or there's pulp tissue for that matter, the EPT will be positive. Okay. Uh, and as for thermal testing, no, same goes, especially for cold. No, they will be uh, positive. No, the difference is for symptomatic irreversible pulpitis. No, this sensitivity will be lingering. Okay, and these are the usual clinical scenario of this will be, of course, you have a carious lesion with and the patient is complaining of more pain usually for exposure to cold, lingering. The patient can also experience spontaneous pain, positional or postural pain. Okay. Um, Also, the patient can complain of, can relay that he's been trying to take pain meds, but they are of little help. Okay, so these are descriptions of that are classic to symptomatic irreversible pulpitis. Now, how would this be different from asymptomatic irreversible pulpitis? Okay, for asymptomatic irreversible pulpitis, no, the patient will not be complaining of any symptom. Okay, so how do you know that this tooth still has a vital pulp? No, no, it will show positive results to EPT and even your thermal test. Okay. Now, how will number one clinically, no, this will have a large cavitation. Okay. Now, radiographically, no, this tooth can have widened PDL space, no, but no periapical lesion, or periodontal see, it's possible. Okay? But it's still vital. The pulp is still vital. Okay? As for pulp necrosis, okay, sometimes the patient will, there will be instances when in the patient will come to you and complain of pain, but then it turns out the story is so long, no, so you have to ensure that the patient, what the patient is telling you is something that's current, okay, no, so the patient might be complaining of something that happened a long time ago, only for you to end up having to wait or having to have listened for so long, and then the story is very different from the current situation. Okay, and because what you want is the current situation. Okay, now yeah, usually for pulp necrosis, you have a variety of possible radiographic findings. No? Okay, in EPT, definitely this will appear negative. It's not negative to thermal test. So, is it possible to get a positive heat test result from pulp necrosis? Yes, and they say it's attributed to the pressure. Okay, that's why there will be some sensation. It's not necessarily pain, but pressure. Okay. Now, in terms of uh, the sensation that's positive for symptomatic and asymptomatic irreversible pulpitis, wherein I said that they would both respond to thermal tests, but the quality of the pain will be different or the sensation will be different. Now, for asymptomatic irreversible pulpitis, it's something that's bearable compared to symptomatic irreversible pulpitis. Okay. Now, for previously treated pulp, okay, you will see evidence of endo treatment, no? Like obturation. Okay, that's what you will see in the radiograph. Of course, it's gonna be negative to EPT and thermal test because there isn't any pulp tissue remaining. Okay? No, and then you have previously initiated therapy, meaning it wasn't finished, but it's a partial endotherapy. No, so it could be a pulpotomy, pulpectomy. No, so you see the pulp at the pulp chamber is gone. No, or you can see that the entire pulp tissue is gone, but no obturation. Okay? Of course, because of this, there's no more pulp tissue there, no? And so negative in EPT and thermal testing. No? So again, no, the best test for checking for the vitality of the pulp tissue is a combination of EPT and code testing. That's the most accurate, okay, in terms of uh, diagnosis for pulpal condition. Okay, uh, please remember this because it doesn't make sense. I had a before there was one student who never discussed a case with me, and but then this student was presenting her TCAP. No, so she was doing the TCAP presentation. This is a compre case. No, and then she on her presentation, she stated that yeah, the chief allowed her to do pulp extirpation upon meeting the patient as an emergency endodontic management, and that's perfectly fine. No, you don't want to uh, cause the patient pain, and this is also a very common misconception, ha. A lot of our patients, and unfortunately even dental clinicians, no, they think that if the patient is experiencing toothache, the patient should not see the dentist. Parang, ha? Isn't isn't that the most important time to go see the dentist if you're experiencing pain? But there's this rumor that's spreading around, no, that if you go to the dentist while you're in pain, that the dentist will not do anything anyway. They'll just prescribe you medication, no, and what they'll do is they will just take not pain relievers but antibiotics, no. And unfortunately, even in the dental wellness center, no, I encountered a clinician, no, who I was just passing by, no, and she was telling her compre patient, oh, we're supposed to do extraction today, but because your tooth is painful, then we're not gonna do extraction. knows, what? No? So you're actually letting the patient suffer from pain because you think that treatment should not be done while the patient is experiencing pain. No, that's a, that's a that's a very strange concept. Okay. Now, how did this happen? We'll go to the apical diagnosis, and then I will tell you how I think this rumor, no, started, and how this has been spreading for years. No, such that common people make this misconception, and unfortunately, even clinicians. Okay, ayan. So apical diagnosis. Okay? So for the apical diagnosis, you have these. Actually, may additional pa dito. Later, I'll show you. Now, so yeah, normal apical tissues. Of course, radiographically, they're normal. No, and of course, EPT and thermal tests are not tests for vitality, but for apical condition rather, or apical diagnosis. It's just that this is telling you that it's possible to have vital and non-vital pulp tissue, no, with this apical diagnosis. Okay, that's why EPT and thermal tests are shown here. Okay, no. So for example, for symptomatic apical periodontitis, this patient usually has biting sensitivity, and of course, alongside this is biting on percussion. Okay, so radiographically, you will either see normal or widened PDL space. Okay? So, take note, for symptomatic apical periodontitis, the common radiographic finding is a normal, no, or widened PDL space. Okay? Now, EPT and thermal testing, positive or negative, this means that this apical diagnosis can come in combination with a, a vital or non-vital pulpal diagnosis. Okay? No, kaya nakalagay dito yung results ng EPT and thermal test. So the symptomatic apical periodontitis is not a consequence of the positive or negative thermal test, because it actually, is possible for either. Okay? So whether the pulp is vital or not, the apical diagnosis can be symptomatic apical periodontitis. Okay? Now, how do you know that it's symptomatic apical periodontitis? Positive to percussion, positive to biting, normal and possibly widened PDL space. Okay. Now, radiographically, there would be some instances where you might see, no, tooth, no, without caries, but the tooth has periapical, widening of the PDL space rather. Okay. So in these cases, you might want to consider the possibility of occlusal traumatism. Okay, so and also, no, endo problem and trauma problem can be coexisting. Okay, so you need to address both issues. Okay, now for the next apical diagnosis, you have your asymptomatic apical periodontitis. Now this time around, the patient, no, is not complaining of anything in terms of uh, pain or what. No. Okay. Now radiographically, you will find a periapical radiolucency or periradicular radiolucency. Okay. This is found in cases wherein you have what, non-vital pulp tissue. Okay. And it's also negative in percussion. So how is this diagnosed? Necrotic pulp, and periapical radiolucency. Okay. Now, as for acute apical abscess, now so usually the patient will complain of pain with swelling. Okay, radiographic findings can be normal. You can have widened PDL space. There could be periapical radiolucency, but take note, no, it can actually look normal radiographically. No, acute apical abscess na to, but normal radiographically at the periapical area. Now, of course, here in this case, because it is an abscess, then the pulp is already necrotic. No? And one other way of knowing that it is acute apical abscess is the positive result to percussion. Okay? So this swelling is your only clue, no? And usually this is the condition or also wherein the patient would come, no, with systematic signs of sorry, the systemic signs of infection. Okay, systematic. The systemic signs of infection, fever, malaria, lymphadenopathy. And this is actually the reason why, no, dentists should prescribe antibiotics and delay any treatment on the patient. Okay? No? But if the patient is complaining of pain and the patient doesn't have, systemic signs of infection, okay? Why? Why would you defer, this treatment? Okay? So so this is protocol. This is now the protocol, no, for if you look up the AAE and ADA, yeah, American Dental Association protocols, no? So ayan. As for chronic apical abscess, no, there would be a bump in the gum or pimple in the gum. Clinically, you will see no sinus tract. Take note, this is actually a very common issue that we encounter. Even old dentists use the term fistula. Fistula is a misnomer. No, gumboil acceptable, parulis acceptable. No, okay. Sinus tract, no, is what's there. Okay. Fistula is an incorrect term. No, but you will see it also. But again, if you look it up, it is a misnomer. No, it's not the correct term to use. Okay. So for yeah, and also because this has abscess, then this will also be related with a non-vital uh, pulp. Okay, but this will be negative to percussion. Okay, so chronic apical abscess. When you say chronic, this is slow progression, slow rate of progression. Now, condensing osteitis, okay, would be in uh, can be in combination with a vital or non-vital pulp tissue. Okay, this is usually asymptomatic, no, but there will be instances wherein there's a possibility of a flare up. May question ba? Nakabukas ang mic. Na-accidentally buksan ang mic. Si Kim. Kim, sino bang host? Kasi hindi ko ma-mute eh. Only the host can mute. Ayan, okay na. Okay. Anyway. Ayan. So, condensing osteitis is usually associated with a slowly progressing disease. Okay. So, or infection. Okay. So this is also, of course, a result of this density of the bone, around this apical area of the tooth. It's also a result of the inflammatory response, but this time of the bone. Okay, well, this time of the bone, just like your abscess, no, it's also inflammatory response in the bone area. But these are totally opposite, di ba? No, so as a matter of fact, both can be present. Abscess and osteitis, condensing osteitis, can be present. Okay, both, no. So for example, you can have pulp necrosis with uh, chronic apical abscess and condensing osteitis. Okay, it's possible, right? So yeah, um, you might be surprised. Okay, a patient can also have acute apical abscess with condensing osteitis. Pwede rin yun, no? Kasi nag-transition yung disease. Okay? So, it's entirely possible that before there was condensing osteitis that was formed, no? But then now it's in acute. state. Okay? No? So, ayan. Hindi ko naintindihan pag yung dentist or yung dental clinician yung nagpapakalat or naniniwala sa weird na, hindi ka pupunta sa dentist or hindi ka gagawa ng dentist kasi masakit yung ngipin. Eh, that's the number one chief complaint, right? No, toothache is the number one chief complaint for dentistry. So why aren't we treating patients who are suffering from toothache? Diba? It's weird, no? But anyway, yun. Um, if you want to wait for the abscess to uh, lessen, okay, pwede rin naman. But really, the only the current accepted protocol, no, is you only prescribe antibiotics for these cases when they're showing systemic signs of infection. Okay, and if I remember, yeah, it's not if I remember correct. I remember Dr. Porter, now one of the members of the apical of the apical of the board of dentistry, no, giving this exact same lecture, no, saying this in her lecture before, no. So, and she would use the term, for example, instead of saying symptomatic irreversible pulpitis with symptomatic apical periodontitis, she would use SIP-SAP, SIP, SAP. Okay? So, yung initials lang. Okay? No? So, pulp necrosis with AAP. So, PN, AAP. Ganyan. No? So you need to know, no, that sometimes this is done. Okay? That's why I'm mentioning it now. All right? No? So, this is another table, but this time around it's showing yung difference between the chief complaint and history. Okay, and other possible findings as well. Okay, so again, it's possible to have combination, no, and here, no, yung focal osteopetrosis or periapical osteosclerosis. Now, this is unrelated. This is not related to pulp, the pulp, no, a pulpal problem. Okay, and you will just see this radiographically. Okay, but it's not related to actually endo. You don't need to do endo here. All right. Now these are possible causes of EPT false readings that you might also want to check out because of course you didn't have an experience using EPT. Okay, no? So uh, some of these factors can be related to the patient's anxiety. They can be related to medication, pre-medication of this patient. Uh, Recent trauma on the tooth would usually present with negative result. No, so you will think, that the tooth is already that the pulp is already necrotic, but this is why you need to wait before deciding to initiate RCT on a tooth that experienced trauma. Okay, ayan. Oops. Okay. Now, this is something that you're not usually exposed to, but yeah, bioceramic materials used in endodontics have contain these ingredients or core chemical features. Of course, not in the same proportions all the time, but you want to see. You might encounter this kasi that's why I'm showing this to you. Your calcium silicate based bioceramics include your MTA. So this is your first generation calcium silicate bioceramic. Portland cement derived powder liquid system. And these are some examples. Your road MTA introduced by MTA. So these are also used for retrofilling also, huh, if you do a picoectomy. Okay. Then you have your MTA-like or MTA-derived, no, or modified calcium silicate cements. No, they're faster setting. Because before, some of the MTA they would uh, set after 4 hours or more. Okay, so this new MTA like or derived materials, no, would be faster setting. They have improved handling, reduced discoloration. Uh, uh, these include biodentine. I've used this before. New MTA plus MTA repair HP. Okay. Then you have your new generation bioceramics. No? So they're ready to use. They set in the presence of moisture, similar to your other MTA, of course, or your other calcium silicate, rather. They have very fine particle size, and these are the examples. No? Calcium phosphate based bioceramics, hydroxyapatite, and calcium phosphate used in bone grafts, perio, and implant. Clinical applications of bioceramics in endodontics, repair, no, direct tissue repair, such as well, examples are your MTA, biodentine, and MTA. They're used for pulp capping, pulpotomy, apexification, perforation repair, root and filling. Uh, you also have bioceramic sealers, which I mentioned earlier. So they're used for obturation. Okay, they're flowable. They can be used with GP. They have minimal shrinkage, and they chemically bond to dentine via hydroxyapatite formation. Okay, yan. So, hanggang doon na lang ang kaya ng powers ko. Wala nang lakas. So, uh, I hope you learned from this review session, no? And if you have any question, you can ask naman. Okay, it's just that yun nga, I can't uh, conduct a very very long discussion, no, and not compromise my health. And well, the quality of what I will present will already be compromised as well. Okay, so yeah, is there if do you have any question? By the way, I think yeah, there are two. Kasi we just had yung what do you call this, uh validation, right? In the list of Clinic 4 students, I think I remember that there are two who did not undergo validation. Okay? So, I don't know why they did not undergo validation, but I'm pretty sure their last validation did not have high percentage, no, of accomplishment. So, it's a bit problematic, no, because if you're not updated, then we don't know your status. You might not even know your own status because you haven't consulted, no, and I don't know, you might have a problem later, no. So I don't understand, no, but yeah, I saw two, no. Oh, and they're both here actually, no. So I'm not gonna call them out, okay, but I saw these two students, no, on the list of Clinic 4's clinicians, but they did not undergo validation of their clinical requirements. Anyway, so that's it for our endo session. No, if you have any question, you can ask naman. If you can't think of one right now, then yeah, just ask later on. It's also fine. Okay? Huh? So, yeah. Thank you, and yeah, enjoy the rest of your Sunday or what's left of it. Okay, bye guys.
Thank you, Doc.
Thank you, Doc.
Thank you po, Doc.